So first, good morning, and I would like to thank organizers for invitation. It is a great honor for me to be here. The second point is that I would like to congratulate authors for this guideline, which is, in my view, very comprehensive text, which in fact I hope will have a great impact into the practice, and I can imagine how big work it was. I am the chairman of, in this moment, I am the chairman of the non-muscle invasive bladder cancer group of EAU, and that's why I will maybe talk more on non-muscle invasive guidelines, but because this is my field. First, I think it is very important just to consider the philosophy when we believe that our guidelines are successful. First, certainly, is the scientific quality of guidelines. We need to, it must be based on the highest evidence, and we must also be able to clearly demonstrate the methodology of the guidelines. It means how we achieve the evidence and how this evidence was translated in our recommendation. But it is only one point. The second point, which is very important for reader, is how it is friendly for the reader. It means you must very clearly formulate the recommendation to use positive recommendation, not negative one. It means to recommend what you should do and not what you should not do. And it is also, you should look maybe on the structure, how the information is presented, because it must be easy to use. It means it is very wise on the end just to look one of your patients and go through the guidelines. And for instance, in your guidelines, if you look on recommendation of RET-UR, it is in fact in two completely different parts of the guidelines, and maybe it can be quite confusing. And the last point is how the guidelines are applied in the daily practice. If some of your recommendation is not applied at all, then you have a problem somewhere, and you should very carefully look on that. The clear example is early installation, which I will talk about. So I think your guidelines are excellent, but I am used that the guidelines are always criticized, so apparently you will be criticized, as I am, and we must say the guideline must be criticized because the next text must be better than was the current one. So concerning some points, and I will certainly talk about scientific point of view mainly. I think this is a very nice idea which you already mentioned, that we should use something how to improve the quality of TURBT. You recommend PDD or narrowband imaging, it means imaging methods or some non-invasive tests. The point is how good data we have for that. My point is that maybe NBI is not equivalent with PDD. We don't know this, probably not. We also have very few data on non-invasive tests. In fact, the best data on that the performance of non-invasive tests improve the result of your cystoscopy. We have, in fact, only on microsatellite analysis, which is not mentioned within the tests here. But I think, and the point is, what is the goal? You know, what we can achieve with these methods. Probably the PDD can achieve better detection on high-risk tumors. We have some data on that. According to not yet published data about the CROES NBI trial, the NBI is better for low-risk tumors in the opposite. I mentioned already the problem of non-invasive tests. And what is the major problem, I think, is whether we can really achieve, by better diagnosis, the better course of the disease. And this is usually, we have no data on that. So apparently, this recommendation is wise, to my opinion, but we will need much more data about that in the future. Risk stratification is a crucial point of all guidelines, because it should help you how to manage your patient according to some criteria and give a clear treatment recommendation. Here you can see your risk stratification and EAU risk stratification. To be true, both are ugly because it is too complicated simply, and we know that. But unfortunately, we probably cannot do it better in this moment. We have too many factors inside, and so you can see how difficult is it to understand that for the reader. I just maybe would like to mention how we achieved our recommendation. What was the genesis of our recommendation? We first, many years ago, when appeared the risk tables from EORTC and calculator, we said, okay, this is probably the best tool which can be used, the best data, the most robust data we have to predict the course of the disease without BCG, without cystectomy. So you know that based on this tables, you can predict the risk of progression and recurrence in all your patients individually according to the parameters you include, and based on that we were able, and you can stratify the patients in different risks according to the risk to the recurrence and progression. And then we artificially decided the patients in the low risk of tumor recurrence, which is about 15% recurrence in 1 year, is low risk tumor. These all tumors are in the low risk of tumor progression, so this is no problem. So these were low risk tumors. Then we said, okay, the high risk tumors are patients who are in highest risk of tumor progression. Interestingly, if you look carefully on the data, some of these high-risk tumors, high risk of progression, are not in high risk of recurrence. It is, in fact, what you showed already in your results, but I think the progression is more important than recurrence for these patients. So this was, and we say, okay, this will be high-risk tumors, and everything what is in between are intermediate risk tumors. Then we made recommendation a couple of years ago based on the risk score the patient can achieve, but it was very criticized and was not used because I believe, for we are all clinicians, and we should probably have recommendation based on clinical parameters. So that's why we translated again the table into the clinical categories as it is mentioned now, and we check that, and really it is how it is given. Now it is quite, I think, scientifically correct. So we really have patients in low-risk tumors are those who have a low risk according to all these data that we can achieve. So this is just how we achieve our results. But in fact, if we compare both recommendations, it is nearly the same. I looked very carefully through that, and there are some differences that you a little bit underestimate some tumors. For instance, small solitary PTA grade 2 tumor who recur longer than after 1 year is low risk in your recommendation. According to calculator, it has about nearly 50% risk of recurrence at 5 years, which is, in our view, more intermediate risk tumors. And more importantly, these multiple and large and recurrent PTA grade tumors have some risk of progression, and 16% risk of progression at 5 years is pretty high in my view, and I don't think these patients should be treated only with mitomycin. This is just one example, but in fact I must underline both recommendations are nearly the same. But in reality, we must very critically look on that. The problem is that the definitions are too complicated, as I said. We use different grading systems. It makes big confusion in this moment, and it's difficult to solve that. The source data which we use from calculator are patients treated very, very long time ago. And moreover, there is not clear link to the treatment decisions. I mean that the trials which we use for recommendation or BCG and mitomycin, usually in their inclusion criteria use different stratification that we are using today. But this is reality, unfortunately. The point of early installation, it is your recommendation is very open, in fact, maybe more open than ours, which was very, very criticized. And what is the problem? There is an extremely low adherence, at least in several countries. It is is really not used. There are several reasons. My opinion, that one reason is that the recommendation is very vague. What is presumably low intermediate risk tumor? It is something a little bit crazy. In fact, we probably need to make recommendation on factors which we know at the time of TURB when we should decide. And that's why we initiated, Richard Sylvester with the non-muscle invasive guidelines group, we initiated the individual patient data meta-analysis, which was performed, it was presented, it is now accepted for European urology, so it will appear very soon. We had individual patient data. Thanks to that, we were able to go into the individual factors, and we were able clearly to show where it was not effective. It was in patients with high recurrence rate and in patients with high EORTC recurrence score. Based on that, you can make recommendation which is based on factors that you have at the time of TURB. It will probably appear in next update. These factors are the number of tumors, how big is the tumor, and definitely what was the previous history. So that's what will come in the future. My point is the intermediate risk tumors and the recommendation of mitomycin only. I still believe, and there are some data that from EORTC 30911 that the BCG was better even in disease-specific and overall survival. In IPD meta-analysis on mitomycin was the BCG clearly better in reduction of recurrence rate in intermediate risk tumors. So this is something what maybe can be discussed. Concerning follow-up, I still, you recommend to, if I understand it correctly, to stop cystoscopies after 12 months, which is very interesting recommendation. In fact, if I just randomly look into the data from just randomly into the trials who published results or the follow-up of patients with PTA grade 1 tumors, there are many recurrences which appear later in this big number of patients. The red curve are patients who receive single instillation, so there are some recurrences later, but I agree that we have no data whether the later detection of these recurrences is dangerous anyhow for our patient. But apparently we need more data about that. How dangerous it is for the life of the patient, which is I think the crucial point. And maybe your recommendation can bring us some data in the future. So it is really very interesting. I'm not sure how in different countries this can be really applicated, because our urologists like to do cystoscopies. In fact, it is advantageous for them, and this is economical point of view, and so on and so on. But once more, congratulations. Thank you for the invitation, and I wish all of you a nice Congress.